Now, thyroid function tests, as I said, are often done on a routine basis as part of screening tests, and they have significance in terms of just being negative. We expect most to be negative, and there are a lot of physiological and pathological variations which happen, which makes it important to be careful in that perspective. Now, one good thing about thyroid hormones are that they have a high basal level, so you do not need to really go ahead in terms of a stimulation test. Second is pulsatility important in thyroid hormones, Dhwani?
So they have pretty stable.
So there is some diurnal variation which we'll talk about, but it's not to the tune of, let's say, cortisol. There is also not like growth hormone. So they will have a stable level. So you don't need to do a pooled sample, so to speak, in that regards. There is limited role of dynamic tests with the exception of what was earlier done, the TRH stimulation test, which we discussed, is already not done much in terms of clinical practice. And usually there is not much effect of timing. We'll discuss about this in more detail as to what will be the best time to sample. But it's not that if somebody has come to you from 200 kilometers, you say you come in the morning tomorrow. It's not like cortisol. It's not like prolactin that you have to do it again from that perspective. So thyroid, the most important assessment, of course, is the TSH, which has got a 40% diurnal and a 50% interday variation. Now, what I said here was, Alapan, that you don't need to really ask them to come back again. But what I'm saying is that there is a 40% diurnal variation. So don't you think that's significant? So what does it mean? If there's a 40% variation, and suppose somebody's true TSH values is 2, then what does 40% variation mean?
So if we again measure it, it could be like around 1.2 or...
So 1.2 to around 2.8. But still, the range is actually 10 times. So 0.4 to 4, let's say. So it's like 1000%. So it really doesn't make big difference if you're having a bit of a difference in that regards. Interday variation is also significant. So you do it today and you do it after some time, you may find some variation which is there. Now, we all know that total hormones are affected by TBG binding, and we'll talk about this a bit later. And there is, of course, an effect of the monodehydrogenase activity in T3, which we discussed very extensively in the last session. And we realized that T3 level is not a reliable marker of hypothyroidism. So it's the worst test as far as hypothyroidism is concerned. In cases of hypothyroidism, we already discussed, in primary TSH goes up, T4 goes down, T3 goes down, but that will be the last test to go down. So in hypothyroidism, best is to do a free T4 and TSH. If there is a if there is a problem there, you expect there is a thyrotoxicosis, the TSH will go down first, T4 will go up. There could also be a situation in which T3 is isolatedly elevated in the setting of T3 toxicosis, and there the role is of T3, T4 and TSH for evaluation. Now, if you look at TSH and look at the diurnal variation, this is the figure. You see the levels are highest around late midnight and maybe in the morning, and they have a dip at night. Now, this is, would you expect this sort of a level, Vibha, from a physiological perspective? What would your body want? You want more TSH at night or more TSH in the morning?
What do you means more TSH in the morning, because all the basal metabolic rate what we eat is during.
Yes. So when you're sleeping, why do you need too much of thyroid? But you see the peak here is coming around 3 o'clock. Why? But you said you want in more morning. What is the time of peak of ACTH?
No, there is a more ACTH, more cortisol in the morning, and there is a suppression effect.
So again, it's pretty similar to what you see from the cortisol curve, but the curve is on the left side. Cortisol starts peaking at around 8 o'clock, midnight, you're the lowest level. So what I'm asking is, why do you think that TSH peak is happening a bit earlier? So
later on the cortisol suppresses it.
No. I'm thinking of thyroid.
That is the time period of low cortisol levels, so TSH rises in.
I don't know. I'm just said cortisol as an example. What I'm saying is that when you have TSH high, you won't get T4 immediately. It will take time for T4 to come up, and your whole activity is T4, T3 dependent. It's not even T4 dependent. So you need to have a 2-hour, 3-hour gap. So that is why you have the peak which is happening a bit earlier. So peak is around 12 to 4. So T4 will go up around 6, 7 and Nadir is around 10 to 4 p.m. Now variation, as I said, Diana, is around 40 to 50%, but importantly, intra-individual variation of TSH is very less. If you repeat the sample in the same person many times, as against you do it in many people at the same time, you will find that there will be much more inter-individual variation as compared to intra-individual variation. So if we say that your TSH was 5 earlier and now it's gone to around 1, do you think that's significant? So what we're trying to say that when you're interpreting TSH, if you have the previous readings, that give you a good idea. If you go the other way around, somebody was around 1 and now suddenly he's around 5, it means that he may be going towards hypothyroidism. So when you are interpreting, also look at what his past history was, because theoretically the intra-individual variation is quite less, while inter-individual variation can be much more. Now, when we talk about the thyroid range, so to speak, as to what sort of TSH range is derived, one of the major factors which influences is the effect of thyroid autoimmunity. So what do you think will thyroid autoimmunity do? When you measure, suppose 100 people and you build a curve, the curve will be shifted more towards the left side or skewed more towards the right side in TSH.
So if you talk about the autoimmunity, it is generally present in most of the patients.
20% people are positive for antibodies. So do you think this will skew the curve towards the right or skew the curve towards the left? Yes, that's there. That should be there. But because of autoimmunity, you think the TSH will be high or low? So 20% people will have a positive antibody. They will be pushing them towards a higher level. So when you are actually trying to develop the curves for TSH, you should ideally look at individuals who are TPO negative. Otherwise, your curves will be shifted to the right side. And that's why people say that all the curves that you talk about 4.5 in adults or 4.4 or 6, they tend to be overestimates because you have a representation of people who are antibody positive. If you remove that, your curve will shift much, it will become more smoother and you will get a much better figure from that perspective. So this is, of course, we know everybody that TSH has a significant surge, which happens immediately after birth, and this follows the TRH surge, and therefore the level remain high, typically very high for 3-4 days, and then they tend to come down, and that's why we do level at the day 3 of life, and then we have got specific cutoffs of 40, 20, and 10 for 3, 7, 14 in terms of TSH levels. T4 levels also tend to rise and then they come down. And what's interesting is that in preterm individuals, you have got a blunted response. So they have a lesser rise of TSH and a lesser rise of T4, which is there. Now, age-specific cutoffs, we've already discussed 40, 20, and 10 as cutoffs for thresholds as far as action is concerned or treatment is concerned for the first week, 1 to 2 weeks, and beyond 2 weeks. Now, if you go further, the level tend to be higher. So TSH range often is mentioned as 6 as the limit, and 10, of course, for treatment. In adults, it goes on to 4.5. For non-pregnant adults, especially for that. For pregnant women, what level are you worried about? So somebody who never had thyroid, you want to keep TSH below 4. So to diagnose, it is 4. So as I discussed, when you have HCG, it decreases the TSH by 1. So that's why from 5 to 4 was mentioned. Maybe from 4.5, somebody can think of 3.5. So whatever is the population range, you come down by 1. 2.5, you're absolutely right, is what is the target you want to keep in the first trimester in that regards. Now, elderly, which Alapan said, they tend to have thyropause. I would say we can use the term that thyroid becomes a bit sluggish in that perspective, and that's why you want to keep it at a higher level of 8 as compared to the other levels. Now, as discussed, TSH is of course a large peptide, and we discussed it's a double chain peptide, and there will be a lot of issues which are there. One important issue is the cross reactivity. We know that its alpha subunit is similar to LH, FSH, and HCG, and beta also has an overlap which is there in that regards. So this could cause a falsely elevated TSH if you're using an assay which has a cross reactivity. So this you have to look at from that regards. Now, very importantly, we know that there are glycosylation. All these peptide hormones are glycosylated, which impacts their biological activity. Very important conditions in which there will be a discrepancy between immunoreactivity and biological reactivity are in the setting of, let's say, hypothyroidism. If your TSH is too much, you will also have increased bioactivity. If you have a central hypothyroidism, you may be producing TSH which is there, which is detected, but it's not working. So you will have non-functional TSH, quote unquote, which can be there. So again, this discrepancy between biological and immunoreactivity you need to be aware about. So remember, in central hypothyroidism, the bioactivity is less. If the body really wants the hormone to be more, you will produce more bioactive form in the setting of TSH-OMA as well. The other important thing, of course, is the complication of macro TSH. Like prolactin, you can also have macro TSH. And how will macro TSH present with?
Will detect on the immune.
So macro TSH will be?
Will be falsely high elevated level of.
So you will have no clinical feature of hypothyroidism, but your TSH level will be on the higher side. And in that setting, you can use a pegylation based thing in that regards. So you have a 10-year-old girl with hypothyroidism on thyroxine 100. TSH was found to be high. She is clinically euthyroid. And then you repeated the test again and you found the level to be normal. So what other clinical possibilities you will think of? So she came to you with a report. You said, okay, I don't believe in this report. The child is fine. Let's do a second sample. The level is normal.
This could be due to the presence of, it could be due to the carryover effect, sir, because
Okay.
if we change the platform and the value has changed, it means there was some, previously the sample that was processed.
Even if you don't change the platform, it may be normal in that regards. So that is something which is there. So basically, it's the effect of that particular assay. Because when you really measured that, the previous sample was very high. And this could be something which is a problem. So this is carryover effect. You don't need to change the platform. You need to change the platform if suppose somebody's TSH is persistently high on one particular machine and you switch over to a different machine, you find that, okay, TSH is normal. That could be because of some antibodies or the heterophile antibodies which may cause confusion. 12-year-old boy with routine screening, TSH is 14, FT4 is normal, and child is euthyroid, TPO is negative. Now, of course, you cannot always say that this could be absolutely asymptomatic because often subclinical hypothyroidism may not have any features. What other possibilities you will think of before starting treatment in this case? There is no clinical features, routine TSH is there, height is normal, no goiter, TPO negative. So in other words, I'm asking what could be the false positive causes of TSH elevation?
With the antibodies.
Okay. So how do heterophile antibodies work?
Heterophile antibodies are some other antibodies, and it may be falsely low or falsely high. Go in the both side. If it is falsely high, during that the plate will be catch the antibody, and again the signal antibody will be catched by that.
So there would be a signal generated because of cross-linking of this antibody with your signal antibody without the reagent being present. That is one possibility. Anything else? You just discussed this. Yeah. So obesity, child is absolutely normal. So this is what we discussed about that. A possibility of a macro TSH can also do this picture. So TSH and prolactin can have a macro TSH effect, which is there. Now, the 14-year-old boy with craniopharyngioma, follow-up after surgery, FT4 is low, TSH is 12. Now, you know this is craniopharyngioma, and you know that surgery has been done. You think this is a central hypothyroidism, but do you think this is primary hypothyroidism?
So usually with low FT4, the expected TSH to be greater than 20. So in this setting, anything less than 20, we should consider a possibility of setting.
And this, of course, is a clinical case. You know that there is a problem here. So why do you think the TSH, where has the TSH come from? And if it's there, why it's not working?
It is an inefficient.
So bioinactive.
TSH.
So this is a known phenomena. So don't get too much perturbed about a slight LTSH elevation, which is there in this setting in that regard. So this was something which was not requiring any particular scenario. So we've discussed about heterophile antibody. It's an interesting scenario, which are non-specific antibodies to multiple species. So if you are exposed to a particular animal like a rabbit or a horse or whatever, you may develop antibodies, or they may develop like just a natural response as well. And often because mouse is horseradish peroxidase or mouse or rabbit or whatever enzymes are being used in a particular kit, and they will vary depending upon the kit that you're using, you may have differential outcome which will happen. So if you have an antibody to the antigen, so what you're doing, you're not linking it to the signal, but you're competing with the antigen, so you will have a low level. If you have an antibody to the assay or the detection of the signal peptide, you will increase the signal. So even without the antigen being there, the signal is produced. So this is something which Vibha was talking about to do in a different platform. So when you say platform, it means you can go for a different type of lab. Now, unfortunately, most labs that are doing now are non-RIA based labs. Of course, they are all chemiluminescence based, but they often have similar platforms. So when you're doing it, you specifically ask about what machine they are using, and only if they have a different machine, then you should consider using this in that regards. The other option, of course, will be a dilution study, which will give you a clue, or an anti-antibody levels you can do. So 24-year-old girl with amenorrhea, Vibha, free T4 is 0.4, TSH is 3.4. What do you think is happening here? This looks like? So definitely like a central hypothyroidism, yes. Now MRI was normal, cortisol was normal, thyroxine was started. Now on follow-up, after a month, the patient wanted to do a repeat level and they found TSH to be 90. So can you think of a condition in which on treatment with thyroxine, your TSH goes up? Now, the other caveat is that this time they had done from their different lab.
So this would be the
So the initial TSH was falsely low. So to begin with, the TSH was reported as low because of the heterophile antibody. Now you go for a proper one. So this was more like a primary hypothyroidism. So that's why primary hypothyroidism was masked as a case of central hypothyroidism. So this is something to remember. So now we've discussed a lot about TSH. We'll talk a bit about T4 and T3. Now we all talked about binding globulin, and we discussed about various binding globulins. The most important, of course, is the thyroxine binding globulin. Then you have got the albumin and transthyretin, which is more perspective of the CNS or the local scenario in that regard. Now, which of these hormones are more affected via the binding of antibodies, Sunny?
T4 is more in the bound form, so T4 levels are more frequently affected.
So the T4 will be definitely the one which is much more affected. That's why FT3 is not something we routinely recommend. Even T3 total will be as good or better, in fact, than a FT3 in that perspective. So if your thyroxine binding globulin is high, like in the setting of estrogen, oral contraceptives, pregnancy or SERMs, most common situation. Also in the setting of neonates, hepatitis, porphyria and mitotane, you will have a situation of falsely high T4 with a normal FT4 and TSH. If the levels are low, of course, in the setting of malabsorption, hypoalbuminemia, nephrotic syndrome, use of androgens, and severe illness, you will have a low T4 with a normal FT4 and a normal TSH. And finally, if there is an effect in terms of the binding, you will have a high FT4, which will happen in that perspective. And very importantly, for salicylate and furosemide, this may happen in that regards. Now, when you measure a free hormone, so that's why the problem is there with the binding, and that's why you go for a free hormone. Now, the ideal way to do a free hormone is a dialysis, equilibrium dialysis based assay. What you do is that you have got a membrane which will filter larger molecules. So what will happen? You will incubate. The ones which are bound to TBG will not be able to go forward, while the free ones will go. So this will give you a good estimate as to how much of your entire thyroid is free. So you measure the dialysate and this is directly proportional to the T4 level. Now, do we routinely get the equilibrium dialysis done? So what is the problem?
Problems are
So of course you have to incubate them. So it's not that you will get the result in 20 minutes. Like if you're using a Alexis or some machine like that, you put it in 20 minutes, you'll get the results. Here you have to incubate it. There would be time consumption. There'll be a lot of cost consumption. The cost is like 10,000 rupees for a single value of this sort of assay. So definitely equilibrium dialysis is not routinely indicated. Which will be condition in which you think this will be of very, very benefit? So in TBG related disorders, why don't measure the analog value? When your FT4 measured via the chemiluminescence is not reliable, that will be. So when your FT4 measured by the chemiluminescence is unreliable, so what conditions would that be?
Illness and pregnancy.
So especially the preterm newborns, when you're thinking of transient hypothyroxemia of prematurity, we always say if you have a doubt, your FT4 is low and your cortisol is normal. If cortisol is also low, you think of MPHD. If cortisol is normal, in that setting, you can do a equilibrium dialysis. That will be the clear-cut indication which is there in this scenario. The problem, however, is that it's time-consuming, cost, and it is not really independent of the effect of heparin or hypertriglyceridemia. Why is that? So anyway, your FT4 level will be high. The free amount of T4 will be high because of that. So this is still going to be something that you have to consider from that perspective. Now, this was the classical assay. We also have an analog assay, which is measuring the free form in a different way. What they are doing is that they have got a coated plate in which antibody is there and you wash and then you measure the bound antibody. Now, this bound antibody will obviously be disproportional to, it will be inversely proportional to the actual level of FT4. So this is something you will get the scenario. It's a fast, it's an automated technique. The problem is it has some effect by TBG. It is not very reliable in low levels and also at high levels. So when are you bothered about? You're mainly bothered about in neonates, in pregnancy and sickness. So all your FT4 level, where you want them to be the most reliable, they are not that reliable. So what I'm trying to say is that now we have moved away, especially in pregnancy, people talk about total hormone levels and using gestation specific cutoffs rather than free hormones. Similarly, sickness, be a bit wary about what your FT4 levels are, and that can be unusually abnormal in that perspective. Now, T3 assay is again largely based upon T4 binding to TBG. So it's an indirect way. When you are measuring a FT3 level, you are using an indirect measure of how much T4 is binding, and from there you see how much T3 is there, and that will give you an idea. So FT3 is a radio tracer based how much fraction is being measured, and then you extrapolate it to the total T3. So it's a even worse test as compared to FT4. So one test which has got no role in terms of pediatric thyroid assessment is FT3. Do not recommend FT3 routinely in that perspective. 16-year-old girl with hirsutism and oligomenorrhea, very high T3, very high T4. They're concerned about thyrotoxicosis. What would you do? Dhwani, the girl looks euthyroid. Will you do a thyroid scan?
This child may be on vesicles, so.
And this is more often than not that they will be on estrogen progesterone, and then you got a free T4 which was found to be normal. 18-year-old boy with ICU admission, FT4 is on the high side, very high, 4.2. TSH is 2.4. Shall you do an MRI for a TSH producing tumor?
The child is in ICU, he must be sick. He must be sick, and that is why we should.
So in sick, your FT4 goes up. So you have to think of the logic. It's not just that they are sick. Why would FT4 go up in sickness? Anything which we discussed can cause this? With a normal TSH also.
And furosemide, they can cause.
So hypertriglyceridemia, heparin, and all those things. T3, T4 was total was normal, and child with euthyroid. He was on low molecular weight heparin. So all these things become important. Remember, when you say heparin, it is not just the in vivo effect. It may also be the in vitro effect. If you're using a heparinized syringe, or if you are putting in a heparin, this thing that can also displace FT4, and you'll get a falsely high level from that regards. Pre-heparin report was found to be normal. So this is something which is extremely important to remember, that heparin will displace the T4 from the binding globulin, and your levels will really go up. 22-year-old girl with thyrotoxicosis, FT4 is very, very high. TSH is very low. There are no clinical features. What do you think? So, falsely positive results which are suggestive of thyrotoxicosis.
Here we asked for the history of any drug intake recently. There are some drugs like biotin that causes suppression of the TSH, and that can cause this.
So biotin can cause the problem, and biotin is actually also part of a lot of assays, the biotinidase, and that can cause a lot of problems in that regards. And you got a very high level. It was because of a biotin effect, and the repeat level was normal. Now we've discussed about how thyroid hormone changes with age, and these are the various reference ranges. You can have maybe this table should be there as part of when you're looking at, because most results that you get are based upon adult reference data. So you have to be more cautious in terms of the use of interpretation of T4, FT4, and T3 level.